Hi friends, I'm back again with the 10th edition of my iterations and reminiscences of the paradigms that have shifted or changed in my last 20 years as an intensivist. I'm surprised that I've actually reached the 10th episode I was able to recollect about 8 such episodes where the paradigms have actually shifted. And in the ninth episode, actually, I spoke about paradigms which are yet to shift or where robust physiological rationale has not met the success of a rigorous randomized controlled trial. So it means that this dynamic specialty is truly dynamic, and it keeps changing and keeps teaching you new lessons every now and then. Some of you might actually be surprised at my attire today, formal attire. If you think it's a paradigm shift, I'm quite happy about it. But I just walked in after a board meeting, so I thought I'll finish this recording as well. Anyway, so while I spoke about the practices and the principles of intensive care which have changed over the last 20 years, I actually have thought about the speciality of critical care itself, the way it has changed over the last 20 years. And today I want to talk to you about a little bit about this. Now, this specialty is a dynamic, wonderful, and very gratifying specialty. I'm sure most of you would accept that. But when I started my career way back in 2000 as an intensivist, now at that time, the IDCCM course was the only beacon of light, was the only ray of hope for all of us who were aspiring to be intensivists. And maybe in 2001, the national board started the 2-year fellowship in critical care. In the first year, it was chosen left to the institutes to recruit candidates, and the second year, in 2002, the formalized entry exam was conducted for all India selection of these candidates, and I was the first batch who happened to come under the tutelage of the legendary Vineet Nair, followed by Jose Chaco at the Manipal Hospital, and I'm grateful that I came under the guidance of these two stalwarts at such a young age in my life. From then on, this specialty has grown by leaps and bounds to the point that it was recognized as a standalone super specialty in 2017 by the the Medical Council of India, which is now known as the NMC, and there was a retrospective recognition given to those who had completed their FNB. Now, this actually boosted the morale of a lot of us who completed our training and went abroad for fine tuning our skills in Australia and the United Kingdom, and encouraged us to come back and take up teaching posts either in teaching hospitals and universities or in corporate hospitals which were keen to run training programs. And that's what I did by starting the National Board Fellowship at Care Hospitals, Hyderabad, and ran it for a good 9 years. So that gave us a good paradigm shift of trying to find your future overseas, then to come back and give back to this country what the country has given to you as an undergraduate and postgraduate and a super specialty trainee. So as more and more such specialists became available in this country, hospitals which were starting new units, setting up new intensive care units, understood and realized that formally qualified specialists in the field of intensive care are required to be on the regular staff of a critical care unit, and that actually was a huge paradigm shift. And more of my colleagues, my contemporaries who qualified and came back were able to find jobs in good institutes and do excellent work over the last 20 years. And so as it progressed, the accreditation boards also understood that the presence of a critical care qualified specialist is an essential aspect of having a good intensive care as far as accreditation standards is concerned. So the emergence of the specialty, this recognition by the medical council, the acceptance that such specialists are required first by the hospital managements and next by the accreditation boards has been a huge favorable paradigm shift for us as intensivists. As the specialty grew and we acquired more knowledge about the specialty, its nuances, its intricacies, and its variations in different organ systems, certain subspecialties did emerge. The prime ones among them being neurocritical care, cardiac intensive care, and transplant intensive care. But the most recent one is the obstetric critical care. Neurointensive care has its own fellowship in this country, which is run by a robust system and exit exam. Cardiac anesthesia and intensive care is again a highly specialized program with its own nuances. Now, with the advent and accessibility of ventricular assist devices, now these skilled specialists will be in great demand across the country. Transplants, the COVID pandemic triggered a whole series of patients who are in need for a lung transplant, and most big hospitals in the country have set up or are in the process of setting up lung transplant centers, and they are not shying away from trying to send their senior professionals overseas to the best of transplant centers with outstanding results to get themselves trained in the intricacies of the immediate perioperative and postoperative care of lung transplant recipients, and intensivists have been in the forefront of these training programs as well. So as the obstetric critical care is again something which is caught on, and a lot of training programs have come in, not least to say that the ISCCM has itself embarked on an online training module on obstetric critical care, which will be launched very soon. So as these specialities have increased and as our ability to look after multiple subspecialties has increased, the need to acquire more technical skills has also increased on the part of a trainee who enters into intensive care. We were only required to learn the basics of chest radiography and CT scan, maybe acquire the skills of interpreting a basic left ventricular echo, and maybe towards the end of our training we learned about vascular ultrasound and a little bit about ECMO. But now every trainee is expected to know a lot about point of care ultrasound, right from the TCD, right from optic nerve sheath diameter, lung ultrasound, diaphragmatic ultrasound, right ventricular assessment by sonography, EFAST, assessment of the renal Doppler index as part of the VEXUS protocol, and bladder sonography for anuric or oliguric patients. These are all become integral skills for an intensive care trainee to learn. Similarly, not only sonography, intensive care trainees are now expected to learn a lot about radiology as well. You need to know how to interpret a contrast-enhanced CT of the chest to exclude dissections and pulmonary emboli. You need to look at a contrast-enhanced CT of the abdomen, mainly for patient pancreatitis and pseudomembranous colitis and intra-abdominal catastrophes. You are expected to know how to interpret the entire stroke series of flare, diffusion weighted, T1, T2 weighted, and spectroscopy images of the. And some of us are probably required to understand, if you're working in a high-end oncology center, to probably interpret the basics of PET CT as well. So essential radiology skills which we were expected to know 20 years ago have increased, and the expectations of a candidate as far as radiology skills has also increased. One of the other areas where the skill sets of intensive care trainees is expected more is in the area of renal replacement therapy and multi-organ support systems. So you have different types of cartridges, not only for renal support, but for poisoning, for lupus, for hyperbilirubinemia. You have the ECMO circuits running with CRRT. You have the therapeutic plasma exchange running with CRRT. So a trainee in critical care is not only expected to know the dose of dialysis, the modalities of renal replacement therapy, but also the other circuits which are possible to be connected to a critically ill patient with a complex multi-system problem. So multi-organ support system has now become an essential, at least a knowledge base, which every intensive care trainee is expected to have. Well, all this has happened. The intensive care trainee is also expected to know a totally different kinds of pharmacological approach to the drugs which he is using in the intensive care unit. So a trainee in intensive care is expected to know the lipophilic and hydrophilic antibiotics, their cycle of distribution, their volume of distribution, whether it's a time dependent or a concentration dependent antibiotic, and how this antibiotic behaves when given in a patient with intermittent hemodialysis, or how it behaves in a patient on SLEDF, or how it behaves in a patient on CRRT, and what if ECMO is added to the CRRT circuit. So the pharmacological competence of an intensive care trainee is expected to be at a much higher level than super specialty trainees of other specialties like cardiology, nephrology, gastro, and neuro. So our knowledge base requirement is probably wider than other trainees. While we acquired more of these skills and knowledge and kept ourselves abreast and become highly skilled operators, we have also become part of teams which are providing intensive care outside the four walls of this ICU. And I myself am aware of several big teams in this country which offer services outside the ICU in the home ICU setup. As the burden of bed occupancy in hospitals increases, more and more patients are now going home on supports. Even when we were not as skilled or as educated as we are now, we have looked after a patient with motor neuron disease on ventilatory support for close to 2.5 years until she succumbed to a pulmonary thromboembolus. So, home care and intensivist involvement in such home care has become very widespread, and that's been a paradigm shift I have noticed in the last 20 years. Not only in home care, the intensive care specialists have become part of the MET teams in most streamlined hospitals. So we have become guides, we have become advisors, and we have become the team leaders of the MET teams to pick up early warning signs and identify those patients who need to be brought into the intensive care and resuscitated quickly and early and appropriately to decrease the burden of critical care on the intensive care and the patient's family. So, this kind of knowledge, the availability of highly skilled trainees, the recognition of this specialty has spawned the emergence of well equipped ICUs in Tier 2 and Tier 3 cities. This has got to be linked with the emergence of tele ICU. I have been enamored by tele ICU ever since I set foot in this country way back in 2006. But there are, I know, very big teams in this country which provide high quality tele ICU service, going to the depth of the country, reaching to the hinterland of the country, and giving advice to people dealing with snake bites, poisonings, an obstetric patient who is seizing, a drowning victim, and trying to give method to what they are doing, guide them by a hand holding approach, and then limit the morbidity which delayed treatment can happen and prevent such sick patient having to withstand a travel of 300 or 200 kilometers to a tier 1 city. So the availability of tele ICUs, the availability of skilled manpower who can man these tele ICUs, and the availability of highly skilled professionals and well equipped ICUs in tier 2 and tier 3 cities has been a big paradigm shift, and I'm sure this will change the face of healthcare, especially intensive care in this country in the days to come. So while we have done this, while we have trained ourselves in so many skills, we have extended it outside the ICU, we have learnt how to guide people sitting in a remote place. Our access to knowledge has also increased, and that's been a big paradigm shift for me. Way back in 2002, when I was a trainee, the only access to us was taking help from some of our friends overseas to give us original articles from the NEJM, Lancet, and CCM. If we were lucky enough to work with good bosses like I did, they were magnanimous enough to give their personal online search portal login IDs to us, and we were able to use them and download information. Otherwise, the only option you had is to walk across to a university library, sieve through a whole bunch of journals and find out what appeals to you. But now, access to information has jumped by leaps and bounds. There are several big active WhatsApp groups operating in this country which give a lot of information whenever somebody wants it. They are able to guide people with good advice backed by evidence and articles even at 2 a.m. or 3 a.m. in the morning, and help people troubleshoot when they need it. Of course, there is the problem of individual personalized experiences being posted on such groups, but it's always good to know a pro and a con view when you are dealing with a problem and you take a balanced decision on what to do for the patient. And of course, there are always others who will give you a balanced view and give you the latest reference guidelines and articles on the topic which you are seeking to understand. So that's been a good paradigm shift as far as I'm concerned. The conferences have increased, the quality of the conferences has increased, and web-based conferences have become the norm. We ourselves have conducted a 3-day online Hyderabad Intensive Care Symposium for the second time this year, and we were able to get a far wider audience than we would have got had we done a physical conference. Probably hybrid conferences are the way to go for future, and that I'm seeing that as a paradigm shift in the way medical information is shared and disseminated to those desirous of acquiring such information. So with all this information, a trainee who appears for an exam is expected to come better informed and with a lot of expectations from the examiners than what we were when we were appearing for exams, whether in India or overseas. So today, an examinee or a candidate who appears for an exam is expected to know a lot about renal replacement therapy, point of care ultrasound, extracorporeal techniques, drug dosing, and whatever I spoke about as paradigm shifts in learning, they are expected to know. So the standards of exams have increased, which means the output of such exams has increased. That means the quality of candidates who are coming out of these exams is much, much better and superior probably to what we were when we passed out of our exams way back in 2002, 2003. So overall, the quality of professionals who are now manning intensive care units has increased and improved, and that's been an excellent paradigm shift for me as well. But what has been the most gratifying paradigm shift for me is that Indian researchers have made an impact in the world of critical care decision making. I will just quote three examples which come offhand to my mind. Is that one of our past presidents being a member of the group that wrote down the Surviving Sepsis campaign latest guidelines. And it cannot be more than an honor for all of us that he was our representative. He was our past president. Similarly, one of our past presidents has been the pioneer for recommending the tidal volume challenge test for assessment of fluid responsiveness. And that has changed the paradigm of dynamic indices of hemodynamic monitoring. Another past president of ours has been an author of a low-cost intervention of high-impact value, the use of doxycycline and macrolide for the treatment of scrub typhus, which is a particularly relevant problem in the Indian context, and to be published in a highly rated and highly accomplished journal is a moment of pride not only for him and his team but for all of us as members of the Indian Society of Critical Care Medicine. So I'm sure there are many such pioneers I might have missed, and I apologize to them for that. But the work of all such path breakers has made the world community sit up and take notice of Indian researchers. And when an Indian research project or a paper is presented, whether in the World Federation or at Brussels, researchers all over the world are sitting up and noticing, let us listen to what these guys are doing. And it was obvious in the last Euro-Asia that the Europeans are actually giving us more importance and have acknowledged our contribution. It's probably going to be the same in the upcoming Euro-Asia as well. So friends, अच्छे दिन आने वाले हैं. It's not a political slogan. I'm saying this for the society. I think we are growing, the paradigms are shifting, the specialty is growing. Yes, there have been instances of assaults on us. There have been instances of the administration demeaning and belittling us, but that's because we are holding the banner and standing in the front. So a front runner, an opening batsman will face a bouncer. It's not easy for an opener, and an opening batsman cannot expect to face a flat track, straight, non-spinning ball. So that's all, friends. I'll meet you again next week with some more quiet contemplations. Have a good day. Bye bye.